The Gait's a really sensitive screen that you can do at the start of any particularly lower limb neurology exam, and can actually, before you've laid a hand on a patient, can actually help you almost get your diagnosis just from the first couple of minutes from a station with a lower limb examination. Essentially, most of the things that could come up in a lower limb exam can be diagnosed from the Gaits if you know and you're targeted in what you're looking for. So I always advocate at the start of any lower limb examination asking the patients if they wouldn't mind walking up and down, and then assessing tandem gait, so kind of heel-toe walking, and then assessing Romberg's. And as I say, with those three things, you can actually diagnose things often, as was the case in my own PACES examination. So yeah, so at the start of any learning examination, do this, or if it's kind of slightly more vaguely worded about assessing coordination, or if it's hinting at assessing a kind of Parkinsonian type case, always start with the gait. So here's just a few of the things that you can look for. So if the gait's a circumducting gait, so this is when people have an increased tone in a pyramidal pattern, and particularly in the lower limb where you have overpowering of extensors over the flexors. So the leg is held in extension with the ankle plantar flexed due to a lesion within the central nervous system, which has led to this increase in tone with the pyramidal pattern, that typical pattern that we mentioned earlier. And here people have difficulty because the knees extended and the ankles held in plantar flexion. People have difficulty kind of bringing the leg through, and so they need to take the leg round to the side in that circumducting fashion to avoid the toes catching on the floor. People can sometimes have foot up splints to hold the leg in dorsiflexion to help with that, and that might be around the bedside, which could be a good hint towards what the underlying diagnosis might be. But yeah, a circumducting gait with the leg going out to the side because of the increased tone in the classic pyramidal pattern that we mentioned before, tells you that there must be a lesion within the central nervous system somewhere. Alternatively, there's a high stepping gait. So whereas with circumducting, the legs going out to the side because the tone is increased, in someone who has weakness of ankle dorsiflexion, not due to kind of overpowering of the extensors and the plantar flexors as you would with a central nervous system issue, if it's kind of a lower motor neuron weakness due to ankle dorsiflexion weakness, people will have a high stepping gait because there, as you bring the leg up, the ankle kind of flops down, as it were, and so you need the high step to allow the foot to clear the ground, and taking it to the side won't make any difference to that. Whereas with a CNS lesion due to increased tone, people struggle with that because bending the knee is difficult because the extensors are overpowering the flexors. With a high stepping gait, it's just easier to bring through straight. And you'll see that then there might be a difficulty of ankle dorsiflexion. So the ankle will be kind of plantar flexing just due to weakness of dorsiflexion rather than increased tone of the plantar flexors. And this would indicate that you're operating somewhere within the peripheral nervous system with weakness of the distal muscles. Like someone's got a stamping gait, it might be that someone has a sensory ataxia where they don't have the clear joint position sense. So the feet just they're having slight difficulty of working out exactly where the ground is, and so you might have a stamping gait in a sensory ataxia. If there's a broad base to the gait, then that might point you towards either cerebellar or sensory ataxia, which we'll come to in a little bit more detail shortly about how to differentiate the two. Or it might be a characteristic gait of Parkinsonism, so someone with kind of taking multiple short steps, if there's hesitancy starting the gait, or if there's freezing during the gait, or when people are turning, if there's particular hesitancy there. There might be the slightly characteristic stooped posture, and also the arm swing is the key thing to look at. Often the most sensitive thing is an asymmetry of reduced arm swing on one side, and that asymmetry, points more towards idiopathic Parkinson's, but generally as a feature of Parkinsonism. So really paying a close eye, not just to the legs. That's always a tempting thing to look at when you're assessing someone's gait, and is most useful for a lot of the gaits. But when it comes to the gait of Parkinsonism, really paying a close eye to the arm swing is also very important. But then, so the gait gives you a lot of information, but then that tandem gait is particularly helpful for, if you see someone who looks a little bit unsteady, or even if they're not unsteady. Some people will have difficulty with tandem gait, that heel-toe walking. And so if that's, often a patient will probably say to you, oh no, I just can't do that. Or if they just try, they can't take any steps. And that suggests that there's either a cerebellar or a sensory ataxia from a cerebellar or a peripheral neuropathy pathology, and so that kind of puts you in that part of the nervous system that we discussed before, and that's where you do Romberg's test. And I still see, with referrals to this day, a lot of confusion about what Romberg's actually means. So a Romberg's test is essentially you ask someone to stand still with their eyes open. If they're unable to stand still with their eyes open, then you can't test Romberg's. Romberg's specifically needs people to be able to stand steady still with their eyes open. And then you ask someone to close their eyes, and so removing the visual input. And so people who have and so when you remove the visual input, you're dependent on your proprioceptive inputs. And so people who don't have that proprioceptive input just are unable to stand still with their eyes closed. And it's often really marked. And again, the patients will often say, no, I just can't do that. So if someone closes their eyes and becomes unsteady, or they're unable to close their eyes because they'll fall straight over, that's a positive Romberg's test due to a peripheral neuropathy and a sensory ataxia. Whereas if someone is unsteady with their gait, has a broad base, is unable to tandem walk, can't heel-toe walk, is able to stand, they might have a slight sway with their eyes open, but when you ask them to close their eye, there's not this significant difference. That puts you in the kind of cerebellar cap. There you are, kind of within a few seconds of starting your station and meeting the patient, you've asked them to walk up and down, assessed heel-toe walking, and done a Romberg's test. And you can often, within those first few seconds, have diagnosed, right, I'm operating somewhere within the central nervous system or the peripheral nervous system, or the kind of cerebellar Parkinsonism type stations. And all we discussed earlier about kind of how you'd clearly present your information for each of those will be relevant. So that's just kind of one example of the teaching lessons. If you'd like to see more information about kind of putting this exam into context, then like and subscribe to the video, and sign up to the course where there's far more extensive explanation of both this and other science.